Alrighty, I'd like to commence the final session for today by welcoming a wonderful friend and colleague, Associate Professor Josephine Beatson. Jo is a consultant psychiatrist and psychoanalytic psychotherapist, and she's been active in the field of personality disorder for many years. She is particularly interested in how early childhood experiences influence personality development in healthy and pathological ways, and in how psychotherapeutic treatments can benefit personality disorders. Jo has supervised, taught, and published widely in this area and is regarded as one of Australia's foremost authorities. Jo's presentation is on trauma, dissociation, and hallucinations. Over to you, Jo.
Well, now I've changed the topic of my talk because I'm being terribly self-indulgent, and I'm going to talk about my journey towards some measure of clarity about psychotic phenomena, or specifically voices in borderline personality disorder. It began in my psych training when I was fascinated by the whole question of psychotic phenomena in BPD. But after I finished that, Harry Chopra and I, a most wonderful psychiatrist, published a paper, Psychotic Symptoms in BPD, and we described a pilot study of 13 patients we had in the hospital. 7 had voices, 11 depersonalization, 12 derealization, and 2 had visual hallucinations. The auditory hallucinations lasted for a few hours and disappeared. Those were transient at that time, with alleviation of anxiety. And the main driving force behind those hallucinations was intense anxiety. Dr. Chopra, the principal author, noted, and I'm quoting now, non-drug-induced hallucinations receive a negative score on the diagnostic interview for borderlines, but they could be part of the phenomenology of BPD and might be of some diagnostic value. Now, he was very right in that. Now, the next public foray I made into the whole issue was in 2006, when I did a presentation at an advanced course. My first hypothesis was that voices in BPD are manifestations of dissociation. By then I'd moved to them being manifestations of dissociation in the face of stress that evokes memories or associations to childhood trauma. The second hypothesis, which I thought at the time was terribly clever, but we won't dwell on it because I don't think it bore any fruit at all. So I just put it there to be honest about what I said at the time. But the first hypothesis was that voices in BPD are dissociative was correct. I noted that they increased with the level of stress and that the content could often be traced to abuse. Words like whore, slut in the case of sexual abuse, and condemnatory remarks in the form of emotional abuse, I think. You're useless, suffer, die were very common. Now, at the time, I said that all patients with BPD who experience voices have suffered either childhood sexual abuse, childhood physical abuse, or witnessed domestic violence. That was incorrect. Many of them had, but many more still had suffered emotional abuse or emotional neglect, which we didn't know at the time. It wasn't, no research had been done about it, and so it wasn't recognised. I also commented that voices in BPD often met criteria for first-rank symptoms of schizophrenia, that hallucinations can persist over long periods, that is, not be transient. Formal thought disorder is not present and affective, reactive, with socialization preserved. Now, at the time, I did a very brief review of cases seen at Spectrum, and of our 62 patients whose notes I reviewed, 65 heard voices for between 10 and 100% of the time. That's very interesting because that really confirms 2 more recent findings. So at the end, I said, In patients with a combination of lasting voices meeting criteria for first-rank symptoms with reactivity of affect, interest in social interactions, lack of formal thought disorder, what is the diagnosis? Now, clearly, I thought the diagnosis was borderline personality disorder, but at the time, many of those patients, certainly the ones with first-rank symptoms, would probably be diagnosed with schizophrenia or schizoaffective disorder. Why did misdiagnosis remain common for so long? Well, I think there are three crucial reasons. The first is that the DSM criteria, right up until DSM-4-TR in 2000, stated that the presence of even one Schneiderian first-rank symptom with social or occupational dysfunction for at least 6 months is sufficient for a diagnosis of schizophrenia. And that did not change until DSM-5 was published in 2013. Second is that many psychiatrists believed that voices heard outside the head represented psychosis. If voices remained inside the head, fine and dandy, they could be diagnosed with BPD, but outside the head, even until 2 years ago, a registrar asked me, was that the case? Because his consultant had told him that voices outside the head meant psychosis. The third reason, I think, is that DSM-5, right up until DSM-5, all the DSMs stated that stress-related paranoid ideation and severe dissociative symptoms, which I would include voices, are transient in nature. Okay, so let's look at these reasons in turn. First-rank symptoms absolutely lack specificity for schizophrenia. That's now been well proven. Sadly, I think the trauma literature that had been talking about that, writing about that for years already, was really separate from the psychiatric literature for a very long time. And so that wasn't really recognized until more recently in psychiatry. Voices in trauma-related disorders, including people with BPD, who experience childhood trauma, found to be dissociative in origin and often meet criteria for first-rank symptoms. Okay, so that was one reason. And we can look at this list. I can give you many other lists if you wish. Voices arguing, voices conversing, thought insertion, thought withdrawal, made emotions, made impulses, made actions. Korzekwa, who did a very fine study, showed that. Other Shirky, I'm not sure how to pronounce his name, he reported voices arguing in 40% of people with borderline personality disorder and 71% with schizophrenia. And no significant difference was found in the frequency of voices commenting, but that was a more limited study, I would say. What is interesting, and I'll just make it as an aside, thought broadcasting does not seem to occur in people with borderline voices. Borderline people, or people with borderline personality disorder and voices. Thought broadcasting has not yet been seen, and that's a real place for some new research up. Now, in 2010, Kingdon and others found that no definitive difference could be found in the phenomenology of voices in schizophrenia or BPD. Specifically, no differences in the location, whether they were inside or outside the head, the number, often 2, 3 or more voices, the loudness, the frequency, and the conviction about the omnipotence of the voices was found. And there were differences, however, in the distress caused and the negative content of voices, much greater in borderline personality disorder, and that's very important. Korzekwa commented on the toxic nature of voices in BPD. Clinical experience in terms of the third reason why diagnosis took so long, clinical experience is now substantiated, that showing that voices can be heard over many years in BPD. They are often first heard in childhood or adolescent, often before the voices in schizophrenia may first be experienced. Slotima and others in 2012 found that the frequency of voices ranged from once per day to once per hour, with episodes of several minutes or longer. So then we moved to a literature review, which we published in 2019. And what that literature review, by now having a lot of research to examine, found that they are dissociative in origin, they're highly correlated with childhood trauma, often meet criteria for Schneider's first-rank symptoms. Importantly, they can be controlling and associated with self-harm and suicidal behaviour, persist over time, and they're often associated with hallucinations in other sensory modalities, including visual, olfactory, tactile, gustatory. Okay. So in the absence of co-occurring primary psychosis, what is now known, and what we found in that review, is that voices in BPD are highly stress-related. Formal thought disorder is indeed absent. Negative symptoms of schizophrenia absent. Affect is not flat, although if people are on psychotropic medication, may have that impression. Bizarre delusions don't occur, and delusions can occur, but they're less frequent than in schizophrenia. Voices occur in 26 to 50% of people with BPD. Suicidal ideation is high. It's higher in those with voices than in those with BPD who don't have voices. More suicide attempts occur. Hospitalizations are more frequent. The distress associated with them is severe, and they're often controlling and believed to be omnipotent, which means that when they instruct self-harm or death, people can very sadly obey them. Findings reach childhood trauma significantly higher in the borderline group with voices than in schizophrenia or those with BPD who don't experience voices. This is the important thing, and I think I said it before. The levels of emotional abuse, emotional neglect are higher than the levels of sexual abuse, physical neglect. Mind you, those are all very high. But the levels of emotional abuse and emotional neglect in those who hear voices with BPD is right up in the 90% range. Whereas sexual abuse 60, 70, physical abuse 50, 60, so on. All right, so emotional abuse and neglect is particularly common in the group with voices. So research really shows a positive correlation between the level of dissociation and the presence of AVH, verbal hallucinations, and childhood trauma. Current anxiety, we've said, can trigger them. The voices back into conscious awareness and other perceptions related to past trauma as well. So when accurate diagnosis of these patients occurs and psychotherapy for borderline personality disorder follows, the prognosis, in my view, is likely to be much improved. Research is needed to determine if that's the case or not. Clinical experience would highly suggest that it is, and I really hope that we will see less and less and less of people who hear voices being really rather automatically diagnosed with schizophrenia or schizoaffective disorder, particularly if they meet criteria for first-rank symptoms. So thank you all, and pleased to answer any questions in due course.
Thank you very much, Jo, and congratulations on a truly remarkable body of work conducted over many years with a lot of thought. And we are happy to accept questions from the floor. Just type them into that Q&A. Jo is here. I will start the ball rolling, Jo. I'm just wondering, you mentioned a really significant role for trauma in people with BPD who experience auditory verbal hallucinations. With the newly coined complex trauma disorder coming through ICD-11, do you expect that there might be some auditory verbal hallucinations cropping up there as well in the absence of BPD, given the trauma is the root cause?
Yeah, I wouldn't be a bit surprised because, again, dissociation occurs in those patients with complex PTSD. But I think we can't ignore that many people with complex PTSD also have borderline personality disorder. They're comorbid, and there are significant differences between the two disorders at present. But absolutely, some people with complex PTSD will have hallucinatory phenomena because of the dissociation. What I hope very much is that they don't meet the same misdiagnosis as met our people who have BPD. I hope that we're more on the ball now. Yeah.
Absolutely, Jo. And it makes me wonder too, given the understanding of voices having origins in BPD versus psychotic disorder is very nuanced, and you're such an experienced clinician that you're able to tease those things apart to a very fine detail. Do you think that newer trainees in mental health are going to be able to be equipped to differentiate the two to stop that misdiagnosis at early presentation?
Well, that's a good question, Gillian. I really, really, really hope so. I like to think that this is my unfortunate position or opinion, that the new trainees in mental health, in psychiatry anyway, that's the one I know about, don't receive good enough training in psychotherapy. But they get a hell of a lot of training in the biological sciences. I'd like to think that they are highly taught about first-rate symptoms and them not being specific to psychosis. And I really, really hope that they will be able to distinguish. I think we're getting there, but I'm not sure. I'd like to think so. Yeah. Yeah.
Maybe we should make your review paper compulsory reading for all trainees.
That'd be good. If they'd read it, that'd be fantastic. Yeah. Yeah.
We have time for one more question, Jo. I'm interested, when you reflected in 2006 on what you published previously, you'd actually changed your position on a few things as new information emerged. Mm-hmm. Do you have any feeling at the moment what might change again in the future to modify what you've arrived at now? Do you have any ideas about what we don't know that we might have more understanding of down the track?
Well, that's a very good question. I think it's fascinating that we now know that emotional neglect, particularly maternal withdrawal in childhood, in infancy in particular, is highly pathogenic, highly associated with disorganized attachment in infancy, which in turn is highly associated with dissociative disorders in adulthood. So I think that's a new finding that I really want to stress because I think it's of such importance. But as for, I think we'll know more and more about the people with borderline personality disorder who don't have high levels of dissociation associated with voices. What is it? Is it about inborn temperament? Is it about that highly sensitive, anxious temperament that produces over time, with all the other things that can occur through the course of child development to cause people to have personality difficulties? Is it about epigenetic effects? Is it about what happens prenatally? We know how important that is. I think we're going to know so much more about brain development according to prenatal events, the timing of prenatal events, the specific timing of postnatal events, because I think there may, why do people with complex PTSD turn on themselves with such self-hatred and self-loathing, whereas people with BPD have that unregulated, dysregulated sense of self? We don't know enough about why that's so. I think it might be something about the timing of traumatic experiences, but I hope we'll find out. Yeah.
I do too. Thank you so very much, Jo, for sharing the knowledge about this complex and perplexing phenomenon that often leads to diagnosis that may not be particularly accurate for the individual. Unfortunately, we have to move on. So thanks, Jo. It's now a great pleasure to introduce a dynamic duo, Dr. Francine Moss and Dr. Hema Jayaram, for their joint presentation on diagnosing BPD in older adults. Dr. Francine Moss is an old age psychiatrist who has worked as a clinician in a variety of settings for over 20 years. She is the director of the St. Vincent's Aged Persons Mental Health Program and the Victorian Director of Advanced Training for Old Age Psychiatry. Dr. Hemalata Jayaram is a senior clinical psychologist and academic with Aged Persons Mental Health Service at Eastern Health, and she has worked across acute settings for over 15 years. Now, we will have a Q&A session at the end, excuse me, of this presentation as well. So please write your answers into the Q&A while Francine and Hema present. Welcome to you both.
Good afternoon. So Hema and I have got not very long to talk about some of the work we've been doing over the last few years. And we've not done this in isolation, of course, so there have been other people involved. And just to give you a bit of a context, this work is about BPD in older people. So the work has taken place in aged psychiatry units. So in both of our units, so St. George's, which is part of St. Vincent's, and Peter James, which is part of Eastern Health. And why were we interested? Well, we know that older people with BPD suffer, and we also know that those who interact with them and care for them also suffer. And we thought that we know that identifying the disorder is very helpful for the person and their caregivers. And we know that looking at this group with a lifespan approach gives us valuable information about the particular challenges faced. And we know that these people can have very long hospital stays and multiple changes in residential care and do not get the care that they need. And we also know that there are a lot of evidence-based treatments, but not so much in older people, but we would really love to see this be rolled out. So what we're going to talk about is a little bit about BPD in older adults. We're going to talk about a tool that we devised and trialled in a small group of people. So then Hema's going to talk a little bit about the difference between the BP group and the non-BPD group in terms of demographic data and previous diagnoses, medication use, family connectedness and behaviour, and also a little bit about where our work might go in the future or where we would like it to go. So as an older psychiatrist, I was taught as a registrar that BPD burns out. So you just don't see it in older people. Which is not true. And there is a reluctance on the part of clinicians to diagnose it, and that's for quite a few reasons. The classification systems are not designed for older people. There's a lack of rating scale and screening tools, and also the presentation it looks different in older people. So this is where really it all began. And so I'll just go back, but Jo Beatson came and spoke to the advanced trainees one day a long time ago, and we had a really very interesting conversation. And from that, the thought was Jo then went ahead and did this literature review, which is very informative. So, as I've said, it doesn't burn out. The acute symptoms may resolve during the course of the illness, but temperamental symptoms such as dysphoria, abandonment, fears, and anger may persist. And what we do know, certainly when you see people at the later stages of life, that there's often a stable period during midlife with good functioning, which is followed by a decompensation. So in late life in the context of the many losses that people face at that time, and particularly the loss of containing influences such as a good job and a stable partner. Just to summarize, so pretty much these are the features that stand out for BPD in old age. And so when we went to devise a brief screening tool, these were the things that we looked at. This is what we tried to include. So our tool takes about 10 minutes to give, and I'll show you some of the questions, 21 questions. We've got informant questions for staff or family. There's 8 diagnostic criteria represented, a comment section, so where you could make some comments about the person, and you had to have a score of 5 or more. And I stress it's not based on DSM-5, it was really based on these features that were outlined in this paper. So that's just to give you an idea of the features that we were highlighting with our questions. That's what it looks like. So it's very straightforward. Do you have do you have a lot of sudden mood changes? Do people say you tend to overreact, etc.? It's pretty quick to give. So when we trialled it, we did it across 2 services, the 2 services I've mentioned, and we asked all the clinicians to refer anyone with BPD from all parts of the service, so inpatients and from the community team. We got consent. We had one investigator giving the screening tool and the other one giving the Xanarini, and the other investigator did the diagnostic interview for borderlines. Okay. And we really picked up everyone that we could. So we went for over 60, and it was people that we knew had BPD because they'd been diagnosed by a consultant psychiatrist. And when you look at the caseload, we looked at all our caseload and we thought it was about 8%. So they had to be able to provide consent. We used interpreters if we needed to. We wanted to make it a bit of a real life study. If you had a little bit of cognitive impairment, you could do it. And you had to be able to do the questions, obviously. And then after that, we looked at all the files, actually, to look at our controls and our group, and Hema will talk more about that. Okay, these are just quickly, so this is just the raw data, actually. So the pink is the cases. You can see it picked up most people. The other screens didn't. That's our controls. We had some false positives. So it was very able to differentiate between people who did and didn't have it. And the informant questions added objectivity. I'll go quickly, but these are the questions that were helpful. Interestingly, the questions that asked of others were really very helpful, the most helpful. The limitations were it's a very small sample, not matched for age. We were not blinded. And then, of course, there's the question, did they have BPD? And so this has been an ongoing question, but we looked at psychiatrist formulation. And just to say that the diagnosis wasn't always clearly stated, which fits in well with what Jo said. So people often were given many, many other diagnoses throughout their long lives. We're going to refine the tool. So more questions asked of informants to circumvent some of the lack of endorsement, perhaps some questions a question to identify narcissism. Okay. All right, now over to Hema to talk about more details about the groups.
Okay, thanks, Francine, for that. And hopefully you can hear me. If in case the slides don't move, Francine, please go ahead and move them. So very quickly, the qualitative aspect was really about ourselves going into and looking at the profile of the patients that basically came under the borderline cohort, as well as in the controls. And some of the interesting findings we felt were really about highlighting the different diagnoses. And I've actually quickly whisked to the profiles while Jo was speaking, and 4 of them in the BPD cohort actually had diagnosis of schizophrenia. So it just shows that, perhaps these things do last a long time before they get interpreted, differently as borderline very much later in life. So yeah, and I'll cover some of these other aspects as well from what we looked at in the profile data. Yeah, Francine, go ahead, my dear. Can move the next one. Yeah. Okay, so the more interesting aspects was the fact that in the BPD participant cohort, we had a total of 22 who participated, and our screening tool was actually sensitive enough to pick up 73% of them. So this was actually very validating for us, even though it was a pilot approach. And yes, the cohort was mainly selected by our clinicians with regards to where they belonged. It's just showed, though, that it was in line with the diagnosis that our screening tool picked that up. But what's more important is the fact that also it was during this study period that 23% got a diagnosis for the first time. And so I think that's something that we needed to look at with regards to a previous statement that Francine said with regards to reluctance of actually calling it out. So it was only during the study period, it felt as if the clinicians felt validated to actually call it out. And clear diagnosis, there were 59% in the clinical notes that had it. One had implied diagnosis, and there were 14% with actually no diagnosis. Thank you. So with the next slide, very importantly, looking at the range of diagnosis, 100% in the BPD cohort actually featured as having either previous or current mood disorder. And that was significant because if we looked at that, it will relate to the sort of psychotropic drugs that they were also prescribed then. 50% had anxiety, and a good large percentage, 41%, also had some addictions. And these were mostly around tobacco, alcohol, and benzodiazepines. What's interesting also was that given that they were an older adult population, we did have 45% screened and picked up for some early cognitive changes. So this is something that is slightly different when looking at the younger cohort. I would think something to think about in working with older people as well as looking at their borderline diagnosis. So anything else significant, I suppose, with scarcity of time, I'm going to allow this to be a table that you could look at. So with medications then, we found that a large percentage in our BPD cohort were actually prescribed antidepressants and not, almost in comparison as well as sedative hypnotics and antipsychotics. So these were the three major medication range that our BPD cohort were. The false positives were about just 5 of them. But what's interesting is they actually had a range of medication in their list, as well as the fact that many of them had ECT. And this is largely because they were either diagnosed with a major mood disorder or with a psychotic aspect in schizoaffective sort of presentation. Yep. Next slide. So with regards to suicidal behaviors and self-harm, one of the things we wanted to look in the profile data was whether or not it was anything different. And what we found with older people was that overdoses were mainly the main means of a suicide attempt. Now, there were occasions when carbon monoxide, poisoning, and hanging were used as a self-harm attempt, but mostly it was around the overdoses. And we also, as mentioned by Francine, it can have happened later in life when the loss of a spouse or a parent. Interestingly, some of the older borderline patients were still attached to their parents, and when the demise of them also created an event for them. So with suicidal threats, we had a range. We had threats to overdose, running into traffic, jumping from a building, even jumping into a river, as some of the descriptions in the profile notes. And there was an element of cutting and stabbing. Interestingly, this was actually higher in the false positives and mostly with those with depression. Yeah. Okay. So this is a table that captures all of that. If there's anything that's significant here is the fact of the help-seeking behaviors. The participants in the BPD cohort were significantly higher in seeking for help with emergency services or contacting family repeatedly, and staff, especially in residential aged care settings. This was completely different to the false positives and the controls. So this was a very significant aspect to this. And with current connections, family connections, as a protective factor, what we found was in the BPD participant cohort, there were actually about 63% of them who were either estranged or had current conflicts where they had no relationship with their family and friends. So that was huge for us in thinking of, providing psychotherapy or any sort of containment strategies. For many of them were lonely then and socially isolated. Whereas in the control section, you actually had 69% of them still currently supported by family and friends. So in the future, what we're looking towards is, as Francine has mentioned, a trial that is going to involve a larger sample size. The hope is for it to be a multi-site, research project, and to use the SCID and possibly also include the geriatric depression scale to capture the mood component. And the idea is to continue to look at the differences in our BPD group as against the controls. And we have currently also been able to establish some relationships with some researchers who come all the way from Norway, and they have been providing some very inspiring motivation for us. And with regards to psychological interventions, this, as highlighted in many of the other speeches before, we actually lack psychologists in the system. Francine, next slide, please. And in just highlighting what it's like in the two services, at the moment, Eastern Health has a few more psychologists compared to St. George's. And what we have is that situation of not being able to necessarily provide the longer term interventions. What we're doing is mostly around brief intervention, and that perhaps is not sufficient. So we're still in crisis short-term management. Now, the one thing that we have done in the Eastern Health perspective is over the last 2-3 years, developed some short-term groups around ACT, CBT, and mindfulness. We have a long way to go with regards to reaching out. It's not currently directed towards just BPD participants. It's a range of depression, anxiety, and stress-related component here. And we have one psychologist who's currently been employed at St. George's in the Hasar team, and she's looking towards developing some groups as well. So we have a long way to go. I mean, we're just at the point where diagnosis is the biggest part, and having a culture change in looking at older adults. And as Satya shared with us in the very early piece, the fact that DHHS has now acknowledged and allowed for services to be beyond 65 years of age is a big win for us in actually being able to extend our services and our specialization and collaboration. So the hope is that we will move now more from diagnosis to actually being able to acknowledge personality disorders in older adults and provide further training for other clinicians. Yeah. So thanking you very much for this opportunity.
And thank you so much, Francine and Hema, for presenting this body of work to us. Obviously, if people thought BPD burned out as people got older, this is very much a sleeper topic that you're busy excavating. So that's fantastic. And I just want to point out that Jo Beatson was the one who decided that we needed to pursue this. She recognised the absence of information and advice and the extent of the problem. So it's fabulous working together with you all to try and get some insights and improvements into this situation. Now, I'm looking at the questions. We probably have time for one question, actually. And you mentioned, Hema, that some of these people were actually diagnosed with BPD for the first time as a result of this study. I'm just wondering, with the difficulties of finding actually evidence-based treatment for personality disorder for any age group, what are other ways that the patient and the family and the staff experiences may benefit from getting an accurate diagnosis late in life?
I can't say enough of the relief that families go through when we actually provide that education and diagnosis, in the sense that it's been my experience in a multidisciplinary setting. Families actually seek that diagnosis as a way of actually understanding how much they have gone through with regards to the splitting and, all other aspects of the temperamental features of what their, parent may have put to them. So I think it goes a long way. And we find that a lot of the adult children are also continue to have damage in them. A lot of them are depressed themselves and have other features of mental health, which, they haven't been able to try and track to the parent. And so this all makes sense. So in an essence, it's almost like a systems approach. We are actually dealing with the entire family. So, yeah.
Thank you both. You're doing wonderful work, and I'm just so delighted to be working with you and seeing the difference you make in your own services. So I'm sorry, that's all we have time for today. But if people do have other questions, please post them. And if Francine and Hema could keep an eye on the Q&A, because I noticed Joe was actually responding to questions during your presentation. I think sometimes you need to actually start the dialogue for people to come up with their questions. So it's not too late. If you're out there in the audience with a question, you may type it into the Q&A, and hopefully Francine and Hema will stay around for a little while and be able to respond. So thank you so much. Now I'd like to I don't want to present again. I'd like to welcome our final speaker of today, Associate Professor Judy Hope. Good to see you, Judy. Judy's a consultant psychiatrist who has extensive clinical and academic experience. She currently holds the academic chair for psychiatry at Eastern Health and is the Deputy Director of the Centre for Education and Research at Belmont Hospital. Judy's presentation title is Personality Disorder. Oh, it's not. It's Improving the Response. Oh, it is. You're part of the PDI. Personality Disorder Initiative, Improving the Response to and Management of Patients with BPD in Emergency Departments. Thank you, Judy.
Thank you so much, Gillian. We're actually a couple of slides ahead. Can we whip back to our first one? It doesn't really matter. I'd just like to say thank you for the kind introduction, and I'm really excited to have the opportunity to speak alongside such a range of fascinating speakers today. And so this was a collaborative project between Eastern Health and Spectrum that aimed to improve the management, the clinician management for people with borderline personality in the emergency department. This work was done, as I said, at Eastern Health, and at Eastern Health, we serve the population of the east of Melbourne. It won't be a surprise to most of you, but we're the largest mental health service in metropolitan Melbourne. And we have a catchment of over 750,000 people. And in our 3 EDs, we collectively manage over 7,000 episodes of care involving mental health presentations each year. And this project was designed and undertaken at the Box Hill Emergency Department, which is located on the city side of our catchment, where I work as a consultant psychiatrist. Now, the emergency department has issues. We all have issues. And amongst them is the sheer volume of people who attend. The emergency department itself critically examines those who recurrently present in order to both reduce the load on the emergency department and also as a mechanism of trying to understand and address the needs of people who attend recurrently. Our emergency department also identified that people with mental health issues who were recurrently presenting were often experiencing high levels of distress and also aggression. And this was in turn causing distress amongst some of our staff in the emergency department. And our emergency department staff felt ill-equipped to manage many of these situations, and at times were feeling helpless and hopeless about providing care. And lastly, there's the perennial issue of pathways out of care, which was emergent. Next slide, please. So our emergency department had a problem. Our colleagues at Spectrum had ideas, and the mental health program that sits within the emergency department wanted to see better care both for our consumers, but also to support our emergency department colleagues. And we became a conduit for communication and collaboration. Next slide, please. So we set up a steering committee with membership from all 3 sectors, and it started with a small group chaired by Sathya Rao and expanded. We subsequently brought on board Jacinta Emery, our lived experience member, and so we can't say it was co-produced, but it was co-designed. And the steering committee, next slide please, commissioned an implementation team, which drew together a group of the most amazing people. This was run with zero budget, zero allocated time, and simply squeezed into everybody's working day because everybody knew it was an important thing to do. I'm going to skip over an introduction of all of these people, but just to point out again the presence of Jacinta there, who as our lived experience member was hopelessly outnumbered, but ended up being absolutely the linchpin of the whole enterprise. She brought with her the lived experience perspective, voice and language, and ultimately shaped what we delivered. Next slide, please. The steering committee also commissioned an evaluation team. And again, there were representatives from the emergency department, from the mental health program, and from Spectrum. And I've managed to leave myself off that slide, but never mind. Next slide, please. And here is a diagram of what we did. So before and after the intervention, we surveyed staff knowledge, skills, attitudes, and experience in borderline personality disorder. In the middle is a box which kind of goes, and then magic happened. What's inside this box is in fact 8 months of robust discussion, planning, designing, arguing, redesigning, making and executing an intervention. And in the end, it was fairly limited to upskilling our emergency department staff in areas of recognition, etiology, risks, treatment and prognosis of borderline personality disorder. Secondly, in understanding interpersonal dynamics. Thirdly, strategies for improving communication and de-escalation techniques. Fourthly, understanding crisis management plans and risk management. Our co-design implementation team devised and produced what you can see, my little images of a podcast, 5 short educational videos and 2 lectures built around the lived experience voice. And these were made available via our e-learning program. We also made some cheat sheets that condensed down these ideas onto slides so that we could show them in the daily nursing and medical huddles. And also we put them up around ED, we put them on the walls, we put them in the huddle areas, we put them in the toilets, and so that we could get penetration. And finally, we had a staff information and patient information sheet. The challenges of delivering this intervention were very structural. The ED is a chaotic and fast-moving environment. The staff have many competing priorities. They work on shift. They have multiple places of work, which meant that the delivered package needed to be short, focused, impactful and accessible. It needed to be repeatedly delivered and it needed to be championed by our senior staff in ED. You'll notice that there wasn't a lived experience assessment component, and that's a whole other story. And certainly it sparked a whole other piece of work which needs to be done in ED around experience of care. These were our survey domains. You'll see their knowledge, skills, experience, willingness, optimism, enthusiasm, and confidence. There were other things that we looked at, but we're going to skip over today. Next slide, please. We had 86 participants at the very beginning survey and 95 at the end. And we managed to get 17 matched pieces, people who have matched pre and post, only 15 of whom had complete data. And they were mostly nurses and junior medical staff. In relation, next slide, please. I'm now going to present the pre-intervention results, and the results will be no surprise to this audience. Half the group rated their knowledge as adequate, and for a third of people, they were rating their knowledge at the beginning of this as poor or very poor. Next slide, please. Skills ran a similar trajectory with poor and very poor in 28%. Next slide, please. Pre-intervention experience was a little more evenly distributed. Next slide, please. The attitude of willingness was a bit more heartening, and this showed a bit of a higher skew towards those, the higher end of rating, indicating a willingness to work with people diagnosed with BPD. Next slide, please. And however, the attitude of optimism showed a third of people rating themselves as low or very low. Next slide. Enthusiasm, again, a third of people poor and very poor. Confidence, finally, showing again a third of people with poor and very poor. Next was post-intervention, where we set off to remeasure those attitudes and skills and experiences. Here we ran into our first problem. This is a graph that demonstrates the number of survey participants who had and had not been part of the or exposed to the actual ED intervention. And what you can see on the right there is for the parts of the intervention that had a lived experience component that were high quality, only 19 of our 76 people had actually been exposed to it. Needless to say, because the samples were unmatched and because of this low exposure, when we looked at all of our parameters, there wasn't any difference pre and post. Next slide, please. Then we set out to have a look at our match data. In the end, there were only 15 people who were matched. And disappointingly, the only domain that showed a significant improvement was the knowledge domain. And you can see in the previous slide, you can see that 6 people had no change and 8 people had some change. And next question was whether the lived experience component of the intervention made a difference. As a research question, we really wanted to look at this because as a psychiatrist working on the ground, we got this informal qualitative feedback that indeed it had made a difference. And there was one physician that commented that that his understanding and practice changed as a result of seeing the material, and he felt quite troubled by his previous approach to people with BPD. So this is, sorry, back one. So this is us dividing it up into people who had and had not seen that higher quality lived experience material. And you can see that there was a difference between those exposed and not exposed to that material. The people who are exposed are shown in orange in this slide. Next slide. And in fact, when we went back and had a look, in fact, knowledge, willingness, and optimism had all changed despite these very small numbers in this group. Next slide, please. So what did we learn from all of this? Our ED staff showed moderately low baseline levels of knowledge, skills, optimism, and confidence, which confirmed that perception that so many staff felt unprepared and also to some extent unwilling to work with people with BPD in the ED. Although specific BPD education was welcomed by many ED staff, there were really significant strategic barriers to the delivery and evaluation of a program like this, like herding cats. And we learned that it's hard but not impossible to do, but that buy-in from the key stakeholders was really important. The low numbers of match surveys and the low penetration of the intervention in the survey participants made it really difficult to firmly establish the effectiveness of the intervention. However, the presence of change in some of those items was really promising. Both the results and the unsolicited qualitative feedback suggested that the keys to successful delivery were absolutely in those co-design principles, the lived experience and the lived experience voice within that educational material. And this work has laid the ground for the intervention to be upgraded in production, to be rolled out across our other EDs with a sustainability program. And we're really excited about that. So in conclusion, I'd like to thank the many, many people involved in this project, particularly Dave, Paul, Gillian and Joe, our research assistant who prepared some of this work, and also particular to Jacinta, who for some reason has got left off this slide in terrible psychiatrist fashion, and to all those amazing people who contributed to this work. Thank you.
And thank you, Judy. It's been such a pleasure working with you, leading the intervention team. And it truly is a challenge to try to implement change to a system that's already working after a fashion, especially one that's as busy as the ED environment. There is a question in the Q&A, which I shall ask. It says, great work by all. Thanks, Judy, for the presentation. What ways could you see the take-up of the interventions being so low now? So I think it's asking how we could improve the take-up of the interventions.
Oh, we have so many ideas about how we could do this. As I said, it's strategically and structurally a really tricky environment to get into the emergency departments. And the key is about repetition and sustainability. And so we think our project was actually pretty good. The materials we developed were really good, and it's about being able to get them into the key players. But repetition is really, really the key. One of the things we'd really like to do is expand it not only across our 3 emergency departments, but more widely than that, because everybody knows that emergency departments are a critical point of care for people with BPD, with a lived experience of BPD, that many people come recurrently. And I think nobody thinks that it's done incredibly well in the emergency department, that that many people, it's variable, many people's experience of care is very positive, but we know that many people's experience of care is not. And we're we'd also really like to be able to demonstrate whether these sorts of interventions really do affect people's experience of care on the ground, and that's why that the consumer and carer and family evaluation of this project as a next step is going to be really, really important.
Mm-hmm. I absolutely agree, and that important realization that it was the lived experience voice that can have the most impact. So if we had to put it into a very compact package, perhaps that was what we would focus on, so that people get to see the end result of the way people experience ED rather than just the top-down education component only.
Absolutely, it was that was the really compelling and transformational part of it, is understanding where people are on a journey to.
Mm-hmm. Mm-hmm. Thanks so much, Judy. And that's all we have time for, I'm sorry to say. So I'm really glad that we actually had this opportunity to have you present to us about this really important initiative. And look, it's not like all bells and whistles at this stage, but it's such a worthwhile project to pursue and fine tune and then hopefully roll out much more broadly. So really appreciate it.
Thank you.
So this brings us to the close of Spectrum's first research forum. I want to give special thanks to our executive, Eastern Health Executive, Associate Professor David Plunkett and Alison Dwyer, for opening the forum and representing Eastern Health's research. I'd also like to extend my sincere thanks to each of our speakers who generously found the time to share the research with us today. This afternoon's presenters were Helen Mildred, Nitin Dewodka, Fiona Donald, Derv Legek, Lucas Cheney, Mithra Nithyanandan, sorry, I'm getting a bit tired, Agarit Al-Kassab, Parry Hadari, Rita Brown, Joe Beatson, Francine Moss, Hema Jairam, and Judy Hope. And a special shout out to our keynote speakers, Professors Bryn Grenier and Suresh Sundram, and also to my co-host, Sathya Rao. It takes a lot of behind the scenes magic to make an event like today run smoothly. And we've had a great team backing us up. Huge thanks to Olivia Smith, Elise Punchard, Demi Petroleus for your amazing efforts at keeping everyone informed and making sure that everything came together so beautifully in the end. I just want to say, if you do have follow-up questions or would like more information about any of the topics covered today, please send an email to the address on your registration confirmation email. And so that's spectrum.research@easternhealth.org.au. And finally, you'll be prompted to complete a quick evaluation survey when we end the webinar. Please do take the time to submit your feedback, as we'd love to hear your thoughts on today to make next year's forum even better and hopefully in person. Thank you again, everyone, for your company and your support, and we wish you a lovely weekend.